Hi, everybody. We are going to continue with our respiratory system part 2. So where we stopped is we were looking at the bronchial tree and looking at the branching of the primary bronchi as it enters the lungs all the way to our alveoli, where the gas exchange will take place. Now, before I go ahead and talk about that, I want to move forward and focus on the lung structure, which makes a little bit easier for you to understand the branching of the bronchial tree. So when you look at your lungs are made up of individual lobes. Your right lung, which is larger, has 3 lobes: superior, middle, and inferior. And these lobes are created as a result of the horizontal fissure, which you can see right here, and the one that comes in an angle called the oblique fissure. The left lung is smaller, and it only has 2 main lobes, the superior lobe and the inferior lobe, separated by the line which identified again as oblique fissure. Now, the left lung is smaller because the apex of the heart has created an indentation inside that, and that indentation is called the cardiac notch. If we look at the posterior view of the lung or medial aspect of the lung, so sideway a little bit, what we would see is this region where the blood vessels and the bronchi are entering the lungs, and these regions are identified as the hilum. And again, you have pulmonary veins, pulmonary arteries, and you have the branching of the primary bronchi. So now that we know that the right lung is made up of 3 lobes and the left is made up of 2 lobes, it makes it a little bit easier to look at some of the terminology for the respiratory branching or your bronchial branching. So primary bronchi, which are again the right and left, it's the first branching coming off of your trachea. The right main bronchi, so this one on the right-hand side, is wider and shorter. So it's bigger because it's supplying a larger lung, and it's shorter because it hasn't been pushed too farther apart because of the presence of the lung. So you notice again, this is short versus the longest structure for the left primary bronchi. Now, primary bronchi branches into what we identified as secondary bronchi. These are also called the lobar bronchi. So remember that your right lung has 3 lobes and your left lung has only 2 lobes. So working based on that, there are 3 secondary or lobar bronchi in the right lung and only 2 lobar or secondary bronchi on the left. Again, it's based on how many lobes you have. Each lobe is going to receive a single branch. Now, again, going farther down, tertiary bronchi are formed from the branching of the secondary bronchi. And again, if you continue farther down, you form really a small branching called the bronchioles. These bronchioles basically means little bronchi are about 1 millimeter in diameter. So they are pretty small. Now, as you continue, you form what we identified as terminal bronchiole, again, smaller even branches, half the size of bronchiole. And those branch into respiratory bronchiole and eventually alveolar duct. Now, the last 2 are not depicted on the picture. So here is what they look like. So we have terminal bronchi. Terminal bronchi become respiratory bronchiole, and respiratory bronchiole becomes alveolar duct, which ends in these air pockets called the alveoli or alveolus if we're talking about only one of those. So why do we care about respiratory bronchiole, alveolar duct, and the alveoli? These are identified as our respiratory zone, as in they play a role in terms of gas exchange. So alveoli are one of their characteristics is that they have an elastic tissue. So basically that elastic tissue allows the lung to expand and deflate during inhalation and exhalation. It also is a reason that if the lung is not effectively attached to the rib cage through its double membrane, it can collapse inside the rib cage and basically create a condition called pneumothorax or a collapsed lung. So what are your alveoli? So alveoli, you have about 300 million of them, so quite a few of them. And although they are relatively small, because you have so many of them, it gives you a significantly kind of unimaginable surface area. So the surface area created by your alveoli is about 1,500 square feet, which is the size of basically an average size of a house in terms of surface area. So imagine your lungs and you have this significant surface area inside of it. So what are the cells that are formed within the alveoli? You have two main types of cells. Type 1 of them, called the type 1 alveolar cells, are made up of simple squamous epithelium with the main goal of gas exchange. And you can see that here, many of these cells, as you can see, which is kind of the cream color cells, these are cells which are type 1 alveolar wall. And again, what is their importance? These are basically where your gas exchange takes place. So if you want to make a notation for yourself, basically these cells are for gas exchange. So you can see basically deoxygenated blood coming over the surface of the alveoli and oxygenated blood leaving. So this exchange that is happening is because of type 1 alveolar cells. Type 2 alveolar cells are made up of simple cuboidal epithelium, and their goal is to secrete something called surfactant. Surfactant is important because it reduces friction as your lungs or your elastic lungs is expanding and decreasing in size. So you want to make sure to limit the friction against alveoli, because again, the more friction you have, the higher the chance of damage to your tissues are. So by secreting, which are basically these green cells you see right here, by secreting and releasing surfactant into the space, and these alveoli will be basically gliding over each other rather than rubbing against each other, creating a lot of friction. Here, they show you a very zoom-in picture of where the capillary network wrapped within the alveoli. And again, in this side, you have your alveoli. In this side, you have your capillaries. And you can see the oxygen is moving from your alveoli into your red blood cells. And carbon dioxide is moved from your blood and transfers into the alveolus. So we have talked about gas exchange. We have talked about the anatomy of the respiratory system as the air passes through each of the structures and organs of the system. But let's take a look at how we actually create the ability to breathe or complete the process of ventilation, which is basically inhalation and exhalation. For that, we need to go back to one of the earlier concepts we discussed, which was the double serous membrane that is present around your lungs, as well as your heart and your digestive organs. But this double membrane was referred to as the serous membrane, and in case of your lungs is referred to specifically the pleura. So pleura has, again, two membranes. What you see depicted in blue color is the outer lining, which is connected to the rib cage, and that's called the parietal pleura. Then the second lining, which is depicted in pink, is directly connecting to the lungs, and it's called the visceral pleura. Now, between these two membranes, you have a very thin gap, and that gap is called the pleural cavity, which has a small amount of fluid inside of it called the pleural fluid or serous fluid. Now, pleural helps you divide the thoracic cavity. It also essential for ensuring the lungs are inflated at connected to your rib cage. Again, otherwise, if this connection is absent, the lungs are elastic and therefore recoil into the rib cage. Here is the second view of what we're describing. Again, here is your ribs and the muscles of your ribs. This layer right here is your layer that is in direct contact with your ribs and therefore would be your parietal pleura. And you have the gap depicted in red. And then the second layer right here in white, which is your visceral pleura directly connected to your lungs. Now, looking at the blood vessels of your lungs, do remember you have pulmonary arteries, which is something we talked about in cardiovascular system. These are the ones that bring oxygen poor or deoxygenated blood to your lungs. And pulmonary veins are the ones that collect the oxygenated blood after the gas exchange and transport that into the left ventricle. They are innervated by both the two branches of the autonomic nervous system, which is sympathetic, also known as fight or flight, as well as the parasympathetic, which is rest and digest, or your quote-unquote food coma. So parasympathetic, which is the rest and digest one, causes your air passageway to constrict. Because again, kind of think about it. If you relax, you don't necessarily require a lot of oxygen in your system, so you don't really need to deliver that. The second branch, which is sympathetic, also known as, again, fight or flight, is when you do want to allow a significant amount of air to rush into your air passageway, and therefore you dilate your air passageway for easy flow of air. Now, there are two main processes associated with breathing. We have inhalation and exhalation. Inhalation, also known as inspiration, and exhalation is known as expiration. So during inspiration, what is actually happening is you are relying on the action of two sets of muscles. Your diaphragm, which is that dome-shaped muscle underneath, it is going to contract, and through its contraction is going to go flatten. So instead of having that dome shape, it's going to go flat. And the second type is the intercostal muscles. These are muscles that are located between the rib cage. And they are going to also contract, and they're going to help you move your rib cage outward. Now, in these changes causes the thoracic cavity to increase in size, and increase in their size causes the air to move in to your lungs. And on the other side, do notice that, again, kind of think about it, and I'm gonna just do a quick drawing for you guys here. If here is my lungs, when I look at some of the pressures, and I'm just gonna kind of give you a number. You don't need to memorize these numbers. When I'm giving you a number, what we're starting with is 760 for inside and outside your lungs, but then when your diaphragm and intercostal muscles are causing your lung to expand, the lung basically gets bigger and causes the pressure inside your lung to decrease. The atmospheric pressure is still, the area around the lungs is still 760. So notice your lung got bigger, the pressure inside your lung dropped. So air is gonna now move inside your lung. So this is the process of inhalation. Again, is it as simple as I'm depicting here? No, but all you need to know for the purpose of our anatomy class is that when you increase the rib cage or raise your rib cage and flatten your diaphragm, that causes your lung volume to go big, right? Your lung gets expanded. That causes the pressure to drop from 760 to 759, and that allows the air to move from outside into your lungs. Now, this is an active process because it involves muscles. However, if you want to do something called deep inspiration, which is basically you inhaling deeply, you also involve additional muscles other than the diaphragm and intercostal muscles, and those are your splenius, your sternocleidomastoid, and your pectoralis minor muscles. And you also use the erector spinae, which extends your back. So you basically, when you do a deep inhalation, and don't laugh at my drawing, but basically you make your lungs much larger. So this is your normal one, but then you can make it much larger, which causes the pressure to even drop down more, and that means more air can move inside your lungs. Now, the process of expiration is almost the opposite of inspiration, in terms of that if the muscles contracted during inhalation, during exhalation, those muscles relax. Now, and do the exact opposite. So if my lung is 760 inside and outside is also the pressure of my atmosphere or the air around me, 760. When I'm inhaling, my lung gets smaller. So that means the pressure is going to be built inside my lung. So it increases. My outside is still the same. So the pressure difference forces the air out of my lungs. So air goes from the higher pressure to the lower pressure. Now, if you are doing your normal expiration during normal breathing, this is considered a passive process because when you relax a muscle, you don't actually use energy. However, if you are doing forced expiration as a deep exhalation, allowing air to get out of your lungs, that process requires activation of muscles like oblique, your abdominal muscles, which is your external oblique, internal oblique, as well as your transverse abdominis. So I always tell my students to think about it this way. When you cough, that's a forced exhalation, right? Or forced expiration. So if you cough a lot as a result of, let's say, bronchitis, then you actually start to feel pain in your abdominal cavity muscles. And that's basically, the reason is because these muscles, these oblique muscles and the transverse abdominis muscles are overworked, which basically causes the pain. Here is a depiction of how does the air moves as when you're exhaling and you're inhaling. Here is the basically the shape of your diaphragm. Notice the diaphragm would create the kind of that dome-shaped structure right here. Actually, let me go forward to the next picture because it makes it clear. So notice that during inspiration or inhalation, we're saying the diaphragm, which is that dome-shaped muscle here, is moving downward, and your rib cage are moving outward. That causes the rib cage to expand, and with it, your lung to expand. When you're exhaling, or the process of expiration, diaphragm does move up, and the rib cage moves in. And both of these causes the rib cage volume to decrease. And that means, again, air is going to be pushed out of your lungs. This is just more for your information. There's a lot of physiology involved in it, so I don't expect you guys to know this. However, if you do have any questions specific to that, I'll be happy to answer them. Now let's look at some of the respiratory disorders we have. So acute bronchitis is a disease that basically is a result of inflammation of either your primary or secondary bronchi. It typically starts as a viral infection, and if it's not treated, it will lead to a secondary bacterial infection. These are considered to be opportunistic infections, which basically, if you don't deal with the viral infection, the immune system is weakened, and as a result, a secondary bacterial infection can target the same area and cause much more severe symptoms. So acute bronchitis is really, people don't get treated for it unless there is a secondary bacterial infection, but they tell you to rest significantly again and drink plenty of fluid. However, do keep in mind that if the bronchitis is not treated properly and you don't get as much rest to allow your body to recuperate, you will start to make it much worse, and that can lead to pneumonia. Pneumonia is basically when that viral or bacterial infection works its way through the respiratory path and reaches all the way through the bronchi and eventually into the alveoli, which is basically where your gas exchange happens. Now the problem is, as the person develops pneumonia, their lungs basically gets filled with the fluid, and this fluid prevents the effective gas exchange between your lungs and your blood vessels. Some of the symptoms is typically high fever, chest pain, and it can be diagnosed if you take a look at an X-ray, a chest X-ray of that individual. For instance, in this case, you can see clearly a development of fluid within the lungs, which in this case is pneumonia. Again, typically elderly are at a higher risk of dealing with or dying as a result of pneumonia, as the body gets weakened and it cannot basically fight off the infection effectively. Emphysema is another one people may have heard of. This is typically associated with long-time smokers or lifetime smokers, or people who live in a very pollutant environment. It is a chronic and incurable disorder because you change the structure of the lungs at the microscopic level. So there's two main changes that happens in your alveoli. One is that they lose their elasticity. So that means that the air cannot be effectively moved out of the lung. And therefore, that means that the air gets trapped inside the lung. You also have the surface area of the lungs significantly decreases. As you can see here, we talked about how having so many alveoli give you a significant surface area, as in about 1,500 square feet. However, as the emphysema starts to continue and expand through the lung tissue, the surface area significantly declines, which means you cannot effectively gas exchange between your lungs and your blood vessel. Typically, the best way to treat somebody who has emphysema is get a lung transplant. These individuals are also dependent on oxygen tank, as their body will not be able to effectively exchange or bring enough air into the lungs for the body use. Asthma is another medical condition. Asthma can be developed if if you live in a pollutant environment, or when a woman is pregnant, they live in a pollutant environment. It increases the risk of the child being born with asthma by 25%, which is significant. Now, what is asthma exactly? So if you look at a normal air passageway, you can see it's wide open, the tissue is not inflamed, and the muscles that are wrapped around the air passageway. These are smooth muscles, they are relaxed. So basically, in a normal air passageway, you have a wide opening for the air exchange between your lungs and the atmosphere. If you have asthma, one of the more common symptoms of it is buildup of mucus. So the mucus lining on the air passageway becomes thicker and basically block part of the air passageway. Another change that you may see on a person with asthma is that they have an inflammation of the air passageway. Basically, you can see the air passageway is tighter because the tissue is inflamed. So that redness is present. Now, if somebody has an asthma attack, this is a scenario where basically an allergen is introduced, and that allergen is triggering the system, the smooth muscles that are wrapped around the air passageway to tighten. So allergen could be different from individual to another. It could be as a result of pollen, dust, tobacco smoke, animal hair. Those all can trigger an asthma attack. And again, the most important change that takes place is that the smooth muscles that are wrapped around the air passageway become super tight. So you already have a higher mucus buildup, you already have inflammation, and add tightening of the smooth muscle on top of that, you're basically going to have a very small area for the air passage, and that's basically limiting the ability to exchange air with the environment. So typically, if you see somebody who have an asthma attack, you can see them basically gasping for air. What is the best treatment for somebody who has asthma? Is to take anti-inflammatory medication. Anti-inflammatory medication basically help you go from the middle picture to more closer to the normal air passageway by limiting the inflammation. However, in long term, the anti-inflammatory medication is not recommended because it does suppress your immune system. The treatment for somebody having an asthma attack as a result of the presence of an allergen is to give them a fast-acting inhaler. The main goal of having that fast-acting inhaler is to stop the muscle spasm, basically the one that causes the tightening of the air passageway, relax the muscle so you go from a very tight air passageway to relatively open air passageway. And lastly, what I want to kind of mention is what you hear a lot, COPD, which is chronic obstructive pulmonary disease. This is airflow in and out of the lungs is difficult for these individuals. Some of the common conditions are obstructive emphysema and chronic bronchitis. So basically, the air passageway are continuously inflamed, and also the air allows to be lingered inside the lungs. So it's basically, or not the air, sorry, the air doesn't stay around, the air cannot get access in and out of your lungs. Typically, people who have a history of smoking or again living in polluted environment are going to be more susceptible to COPD. Based on what we have heard regarding our current situation with COVID-19, this is also put people who have COPD at a much higher rate because they are more susceptible to any major changes in their respiratory system. And I like to just kind of point out this picture. This is a scanning electron micrograph of the emphysema patient. So on the left-hand side, you can see a very clear example of a healthy, normal lung tissue, lots and lots of alveoli, lots and lots of surface area. On the right-hand side, what you have is significant decrease in the alveolar surface area, which basically makes the gas exchange very difficult. Last condition we are going to talk about is cystic fibrosis. Cystic fibrosis is an inherited medical condition. inherited medical condition. And this is a condition where the body produces a significant amount of fluid, and that fluid is basically gets stored stored inside the lungs. And kind of imagine the alveoli are filled with a mucus or fluid that limits the gas exchange. This very thick, viscous mucus makes it very difficult for the individuals to effectively gas exchange with their blood vessels. And the best way to, unfortunately, treat these individuals is to take medication to loosen up the mucus lining and then hit them really hard in the back to dislodge the mucus from their lungs. A lot of people who have cystic fibrosis, unfortunately, do not live long because there is a lot of problem with that lack of oxygen in their system. Right, so we are done with the respiratory system. We'll continue with our next lecture later on.